Hey, Fix listeners. I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So, if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
And welcome back to the Fix Podcast. I am super excited about today's episode. I know I say that every time, but this time I mean it a little bit more than I usually do. So today we have an absolute powerhouse of speakers in here. If you combine the number of arches that have been done between these four people, myself included, I'm sure you'd be somewhere in the thousands, maybe 5 digits. I don't even know. But today we have Dr. Clark Damon, who is returning to the show. Welcome back, Clark. And he has graciously brought on his good friend and colleague and mentor to all of us, Dr. David Zelig, who instructed me not to call him doctor, but I'm from the South. It's going to be hard for me to avoid the formalities. But just as a brief intro for David, as he likes to be called, he is a board certified oral and maxillofacial surgeon and a nationally recognized leader in implant dentistry. Dr. Zelig, David, earned a bachelor's degree from the University of Memphis, followed by his DDS from the University of Tennessee College of Dentistry, and completed his residency in oral maxillofacial surgery at the Long Island Jewish Medical Center. His years practicing in Memphis, David served as an associate professor in his Department of Oral and Maxillofacial Surgery at the University of Tennessee. He was an active member of his craniofacial surgery team, specializing in orthodontic and TMJ reconstruction alongside his implantology practice. Since relocating to New York, he has held key roles with Clear Choice Dental Implant Centers, among several other centers, where he leads advanced implant surgical programs, including full arch, zygomatic, and pterygoid implant procedures, and a host of other procedures we're going to be talking about today. David is also contributing author in the textbook Remote Anchorage Implant, Leave No Atrophic Maxilla Behind, quite a title there, which focuses on zygomatic, pterygoid, transnasal, nasopalatine, and transsinus implant techniques, featuring case contributions and protocols from leading surgeons in the field, including himself, of course. So David, welcome to the show. That ended up being a whole lot more jumbo than I ever planned on, and I think it was still abbreviated from your actual career. But again, welcome to the show. Thank you so much for sparing your time. I'm so excited to learn from you today.
It's actually pretty cool to hear a eulogy about oneself and to be able to speak afterwards. But thank you for those words.
Of course. Now, did that more or less summarize your career? I'd be interested in how you would add to it. What sort of things you hang your hat on? How would you define your career as well? Just to give the listeners some background.
Well, I came out of residency and started my own practice in Memphis. Yeah. So I'm the Southern guy. The Southern part of me is still polite, but
excellent.
It turned into a full scope practice, and I was very proud of that. Coming back to New York years later, after 20 plus years of private practice, back to New York, I got really very active in trauma surgery, and we'll talk about it later. I think that helped. That just, the more you can do makes you a better surgeon. So everything you do, even if you distill your life down to arches, anything you can do to make yourself a better surgeon helps. And my professional life is distilled down to arches.
So, of course.
That's what happened.
Yeah, absolutely. And can you tell us a little bit about your current clinical practice? We were talking a little bit before we turned on recording. It sounds like you're going around to tons of centers, helping folks out with remote anchorage cases, still getting yourself bloody and helping people out of trouble and, putting out fires all over. What does that look like for you?
Well, I was an early, I drank Palomalo's Kool-Aid kind of early in my career, and, brought that deal on 4 idea to Memphis years ago. And then when I came here, kept that up. And after a lot of trauma surgery and orthodontics and others, still doing arches at the same time, I was approached by Clear Choice to open a couple of their centers, and it was pretty much focused on arches. And when that got so busy, I started mentoring some juniors, and when they got proficient, I was left with only the extreme arches. And that's where I am. So you can't have enough extreme arches in one place. So
Mhm.
I'm running around to a lot of different places doing their extreme arches.
Wow.
That's what's happened.
So
Well,
you're the
Very
fixer.
well, that's really cool. So, I just have a question. So when did you go to the Malo clinic? Like what
Oh,
kind
he
of
first
talk to me
well,
about
he,
that path?
first I drank his Kool-Aid in this country first. Actually, one of his early students started teaching it in Kentucky, and I went to I think it was Lexington way back when, and then learned from Malo after that, and just I don't know what to say when I think it was Bo Rangert that kind of convinced me to say that, wow, I'm using engineering principles here, and we're bringing engineering into dentistry. And when I say it's a bridge, like going over a river, and how many abutments you need is based on how thick the roadway is, that kind of thing. It was engineering principles. It hit me. I guess I was a physics major in college. Not that I remember anything about physics anymore, but that kind of it resonated with me. It made sense.
Right.
So
So did you wait until the 2011 article came out where he kind of published like his first 245 cases, or were you doing it sooner than that?
no, I was early 2000. It
Okay.
was before 2010.
It was
well
Kool-Aid.
before 2010. Yeah. Yeah.
David, can you talk to us a little bit about, how you've seen from the early 2000s? Because you're probably one of the first guys in the U.S., to really take it on. Maybe not the first, but like in that first realm. And maybe, what things you've seen change over the last 2 decades. Pros, cons, that
Sure.
kind of thing. That'd be great.
Well, two things really. First of all, we all came from dental school, and we all respect bone, and the idea of bone reduction was anathema to all of us, and that was the big thing that we had the big river to cross to get to effective all on X treatment, was that amount of bone reduction. So I think all of us were a little hesitant at the beginning doing the bone reduction that we really needed. And I don't mean just to hide a transition line. I'm talking about to get a good all on 4 shelf table to be able to get implants in solid bone, to apply the other principles that other giants gave us, like Dennis Tarnow, of a couple of millimeters of bone buckle and around the implant. So that was one thing that's changed. The other thing that changed, I think that, prosthetic materials, certainly, the initial acrylic bridges that we were using worked nicely, and maybe did have the idea of some shock absorbing effect on the implant, but they ended up looking horrible after a year or so. So moving into ceramics, zirconium certainly was a big deal. I think those are the real advances as we went along.
It's amazing, because I was doing arches probably 2013 is whenever I started, and hit them pretty heavy. And looking back from really 2013, which I felt like I was fairly new. I mean, I wasn't one of the first, but it still in 2013 I was having to deal with the dogma of bone reduction, right? The dogma of taking out a few healthy teeth, and the dogma that was also like, hey, these are all going to fail really, really soon. And it's amazing to see where we are today. And I really kind of think like right around COVID and maybe a touch before, it really seemed like the implants got so much better. Like 2019, 2020, the implants that we have and the abutments, it just seemed like everything got so much better. Do you kind of feel similarly?
It's interesting because I'm looking back at, unfortunately, when I first started learning all on 4, I said, wow, I need to go to a course to learn how to put in implants that aren't parallel. All of my implants were parallel. It was a learning curve. All my implants looked horrible. And I look back at them. The idea of doing fewer implants, as opposed to arches of 8 and 10 implants, was another river to cross. And you look at the failures of those arches with the titanium overdoses and that kind of thing. And when they fail miserably.
Yeah.
Even if an implant fails in an all-on X, you at least have more bone because you haven't occupied the entire arch with titanium. So I think that was a benefit too. Early, listen, I was doing implants when they were machined surfaces, brown marks, and then later hydroxyapatite coated implants, and that didn't work out. I did press fits. We went through the whole. Yeah. I went through the whole. Wow, I'm sounding like I'm sounding like Phil Tatum or something right now. I don't know, you bullshit or something. Wow, I don't know how that happened so fast, but I went through that. And yeah, so the implants did get better, but I think we also, just the understanding of the principles, it finally clicked.
Yeah, I think the general trend has been that, through clinical practice, we've kind of discovered, what works and what doesn't. And we've had a lot of people doing that hard work to go through all the things that didn't work. And now it's getting down to the actual product level where, a multi-unit is shaped in such a way that we don't have to bone profile as often, just all the little nuances is now, we're now kind of programmed in to make full arch a whole lot more predictable. There was a lot of grunt work that happened in the past 20 years or so to get us to the point where, we have things that just work. And I'm not sure that, people like myself and Soren that have, come out in the last, half decade or so and been doing this, I don't know that we can fully appreciate all the things that came and went to get where we're at. And we love talking about not just the things that got us here, but where we're going. But we certainly appreciate that we're coming into the game after people have already spent so much time figuring out all the things that didn't work. So we do appreciate, you guys contributing to that body of work, of course.
Well, that's actually a very, they say that there are 3 kinds of people. Some people can learn from a book, and some people can learn from other people's mistakes, and some people got to pee on the electric fence themselves. And it would be preferable to learn from someone else's mistakes.
That's right. That's right.
Yeah, I mean, so I remember using the Nobel system, and you had to the abutments didn't always fit very well onto the internal connection. And then you had to profile every single one of those. Yep. And what's kind of a funny story is in 2017, I bought a ton of Nobel implants. And then I think 18 or 19 switched over to Neodent. So I didn't have to bone profile anymore. And I just left, literally, I think in my Amarillo office, I left 500 Nobel implants.
Wow.
And so rolling into 2021, I was like, these things are all going to expire. So I had to do probably, 60 or 70 arches.
To purge.
All with Nobel. And it's so frustrating because you have a bone profile surgical kit. You have several, you have to have so many surgical kits out to do a case. And then, lo and behold, if you want to do a 4.0, well, then you got to reach for a Speedy Groovy kit. And then that has its own bone profilers and different abutments. I mean, it is, my assistants hated 2021 because we were using all these antiquated systems. And it's really hard doing pterygoids and having to bone profile back there. And, if you're concerned, is your abutment seated all the way, because that Nobel multi-unit abutment doesn't have a full 360 degrees connection. So it's really interesting, all these things that we take for granted now that really speed up our surgeries.
Yeah, absolutely. I'm sure your assistants weren't too happy if they forgot to sterilize one thing during your kit, and then you're get out of here.
Well, or if they lost the bone profiler, the little guide that sits on top of the implant once it's placed, and if it's a Speedy Groovy compared to a Nobel Active, they're like, these things look like healing abutments too.
Oh, they look like nothing. Yeah, they're way too easy to lose. Yeah,
lots of stuff. You missed the Nobel zygomas though, didn't you?
Yeah, I got a bunch of them right up here. You know?
Okay. That was another one with a mount that was impossible.
Yeah, we'll try my first quad that I ever did after in like 2016 or something, or 15, I broke the mount inside of the 45-degree abutment, and so there's a whole screw in there, and you're trying to back a screw out after your first quad zygoma case. Luckily, I had a colleague that was there who was like, "Hey, you did the case. Let me back out the screw for you." And so luckily he navigated that. But yeah, whew, lots of
Great time.
lots of frustrating things. That's for sure.
No kidding.
So
So David,
we,
go ahead. Sorry.
we've, all right, I was just going to say, we have gone through, like, with Clark previously, a lot of the 0 to 100 when it comes to full arch, basics, what you need to do to get started, good protocols to learn prior to, tackling your first arches. So today, I think what we wanted to go over was a lot more of the remote anchorage, transnasal, quad zygoma stuff that you excel in. So I'd love to kind of start our discussion on that with talking about transnasal, like the Z point and that kind of thing, and go over your expertise on what, if doctors are looking to get into transnasal, maybe what continuing education you'd recommend, key anatomical points, that kind of thing would be very, very helpful for our listeners.
And I think starting first, we should just go with definitions. Like what is a transnasal? What is a Z point? So we know what we're
That'd
doing.
be a good start.
Yeah.
All right. Well, the first thing that came out, and Malo wrote about it, Ole Jensen wrote about it, others wrote about it, was the transsinus implant. Was the idea of using, to get, whether it's because the sinus anatomy is such that the anterior sinus wall is anterior to ideal position, or just to extend the AP spread. A transsinus implant is one that has crestal anchorage underneath the sinus and apical anchorage at the lateral nasal wall, with nothing in between, going through the sinus with the membrane lifted, ideally, but plus minus lifted membrane. But crestal anchorage under the sinus and apical anchorage at the lateral nasal wall. And the idea here is, in a transnasal, is going to go bypassing the lateral nasal wall, having crestal anchorage underneath the nose and the subnasal bone, and apical anchorage at the lateral nasal wall. Well, in this case, the implant is at the lateral incisor position, just as an anterior zygoma would be, or an anterior implant. But if you don't have enough subnasal bone to put in, whether it's endpoint or towards the nasal crest of the maxilla, the alternative is to use the subnasal bone, if you have at least 3 millimeters plus of subnasal bone, and then get into the lateral nasal wall at this junction of, and I call it the confluence of, the lateral nasal wall, lateral maxillary wall, anterior to the nasolacrimal duct, at the level of the inferior turbinate. You got that? It's kind of three-dimensional at this
We triangulated it, yeah.
And that is the target that some people have called the Z point. I can't call it that, but
So
You're too long.
where do you think that name comes from?
the Z point,
Yeah.
I think Dan Holtzclaw did that for
So-
me. He calls me the pioneer. I don't want to be a pioneer. I just want to follow giants that I stand on their shoulders. But that's the idea. So the apex of the implant is in the lateral nasal wall, at this confluence of lateral nasal and lateral maxillary wall. And the posterior margin is the nasolacrimal duct. And fortunately, the ENT literature has done our work for us to help define where that is and where we can find that preoperatively on CT scans. And there's, in 2/3 of the population, there's adequate bone for this implant. The apical anchorage I'm talking about, 2/3 of the population has it, where there's enough bone anterior and enough thickness anterior to the nasolacrimal duct. As far as training to see it, I'm technically the way I teach remote anchorage, except for the pterygoid, is visualize everything. So there's no minimal invasive surgery for a zygoma, in my opinion. Not because you can't get the zygoma in the right place, but it helps you avoid some of the complications.
Right.
So wide exposure, seeing the entrance and the exit points, do exactly the same thing with the transnasal. visualize. What made it reasonable for me as an oral surgeon is because, I've been there before for orthodontic surgery. So you're in the nose a lot. You know what you're looking at, you know what to avoid. But it's eminently teachable. This is pretty clean, direct dissection. As far as education, you ask where you can get this, where you can learn this. Well, you can learn it in books, but you got to see it and do it. So unfortunately, early days when I had dark hair, there weren't a lot of courses, and there certainly weren't books for any of this. And you just had to base what you did on principles that existed before. So that's generally what I've done, is use previous principles and kind of expand on them. In this case, now there are cadaver courses, there are live surgery courses, there's mentorship. There are a bunch of us guys that are willing to go around and look over your shoulder and hold your hand. It just didn't exist in our field. It didn't exist 10, 20 years ago, but it existed in medical education. Medical education is really interesting. If you think about the way internships and residencies, there's someone holding your hand at the beginning, like riding a bike with training wheels. And slowly, as you get proficient, they're watching you holding your hand, almost literally. And then they let go of your hand, and they're still watching. They're still holding the bicycle seat as they're running down the driveway. And eventually they let go, and you're flying on your own. And we finally have that in dentistry. We just didn't have this before. And it's nice to be able to say we got cadaver courses and live surgery courses and mentorships, and it's all out there. Back in the day, I flew all over the world to watch people do these things. Literally all over the world. It was crazy because there was no place to go officially, just nice guys that let me watch. And eventually you just got to a point where you say, I got to do it. And that's what it was.
That's really incredible, David. Just the lengths that you had to go to go and
it's fortunately we're living in better times for some things. For some things not, but for this
we have podcasts now. You can save yourself a flight.
Now back to the transnasal. So it really is an alternative in many patients for a quad, for the anterior zygoma of a quad zygoma.
And this is something I'm curious too about, David. And I actually I took the liberty of messaging a few friends that we were going to be interviewing you, and got some questions back. And so my good friend Dr. Sean Lan out of Atlanta, Georgia, he had been reading through your 2025 paper on the placate guidelines. And he's asking, would engaging the lateral, with regards to the Z-point implant we've been talking about, he said, would engaging the lateral nasal wall be a viable alternative, or would you go straight to an anterior superior zygote? So I guess what he's saying is, if you had difficulty engaging the Z-point, or if it were insufficient, is there a world where you would go through that subnasal bone and just engage the lateral nasal wall, as opposed to finding that conflict?
Yes, there is one type. Well, in a way that is still it is lateral nasal wall that this is engaging, even in an ideal world. But so here's the thing. The lateral nasal wall in about a third of the population is what Daniel Simon classified as a type 3, where there's a lot of space between the nasolacrimal duct and the anterior edge of the lateral nasal wall, but it's very thin. And in those cases, I term it exteriorized. As you're going up the lateral nasal wall, you're hugging the lateral nasal wall, but because it's so thin, it's dehisced on the nasal side, not through the nasal mucosa. It's still deep to the nasal mucosa. And on the facial side as well, halfway up. But the apex is still in solid bone. So the answer is, you can do that. That lateral nasal wall is, as long as it's surrounded by bone. And the higher you go, it gets thicker as you go, as long as you can locate where that nasolacrimal duct is radiographically. So the answer is yes. The only place where you really should not do it is in what Simon called the type 1, where there's no space between the nasolacrimal duct and that edge of the lateral nasal wall. And also in very hypoplastic maxillas, not just severely atrophic, but hypoplastic, where there's a real class 3 AP relationship, because this implant is palatal to the crest, as opposed to a anterior zygoma that's on the facial aspect of the crest. Right. So you would actually make your AP discrepancy worse.
Yeah, that's actually something that Simon O made a post about. I
Yeah.
think it was maybe 3 weeks ago, and he was talking about disadvantage of the transnasal
Right.
versus doing anterior superior zygo is
Right.
that you have a lot more prosthetic flexibility when it comes to
Well,
doing anterior superior. Whereas with that transnasal, you might just
in
be fixated into that palatal
in
position.
in a non-hypoplastic maxilla, in a normal position maxilla, I would say that 90% of my transnasals have a 17-degree multi-unit abutment coming forward, and it puts it right over the lower incisors. So that's
That's
generally where
fantastic.
I go.
Great.
Generally
Great.
where it goes.
Yeah.
So
And go ahead,
this
Clark.
was one of the questions that I had for you, David, in regards to some prosthetic challenges, is with the class 3 patient. So, obviously we want to avoid a significant anterior cantilever. And, my question there is, if you have a very hypoplastic mandible, oftentimes let's also say maybe their zygoma is, not very tall. Maybe let's just say it's, 15 millimeters, right? I don't know if I've seen a zygoma that short, but let's say there's one or it precludes you from that. So you're almost forced into doing this on a class 3. Would you then prosthetically recommend that we, maybe bring the mandibular teeth back and kind of retrocline and just
Yeah.
kind of pull everything back in so it's not as anterior?
Yeah, I think there are a couple of things. First of all, there's still a place in the world for orthodontic surgery. And if we all, me, you, the patient, everybody understands that in an ideal world, we would fix your skeletal deformity before we did anything else. If we're accepting that we're not going to do that and we're going to camouflage or we're going to compromise, then sometimes you have to compromise your occlusion as well. That end to end, edge to edge occlusion may be the best you can get, and lingually decline the lower anteriors to get back, as an orthodontist would do, camouflage, non-surgical orthodontics. So that is a possibility. There's really no other alternative. I mean, the alternative, of course, is grafting, major grafting, but I've been that gamut, and long term, that just is not a good answer.
Right.
In my hands, even the patient specific implants, these subs, you can't correct that much that way either.
Right.
You're still on the same base of bone.
So I'm curious about this too, because I think it was Dr. Zach Brown that presented on this recently at the last Orca symposium. He talked about prosignathix, right? So this thing that we're able to camouflage and compensate for these things with prosthetics. When you're evaluating these hypoplastic cases, severe class discrepancies, where do you kind of draw the line, and how do you draw the line between this really is an orthodontic case, or no, this is something we could accomplish with just some prosthetic black magic?
So, I mean, age of the patient realistically is one thing.
Mhm.
I mean, we really have to think about what's realistic for the patient. We can explain it to the patient, give these options out there, but that's a whole lot to expect anybody to go through nowadays, especially in this age of instant gratification.
Of course.
Like final arches, final teeth in 24 hours.
Yeah.
We can discuss that in a minute too, but I think that's a big thing. A patient can explain you can explain everything to the patient ahead of time, and smile design is critical ahead of time. Really get a smile design, show a patient what you can do, even if it means in plastic. Just show them what you can do, what's realistic and what's not. I think that these huge anterior cantilevers are just as bad as a huge posterior cantilever. There's only so much you can do with a nasopalatine implant to try and avoid an anterior cantilever. It just doesn't go as far as you want it to. So these are things you have to consider for long-term solutions.
Definitely. So as far as when you're doing these transnasals, is there ever an indication to do any grafting? So if you were to elevate the membrane, is there any reason that you would want to pack some bone in there? Is there any possibility you get some bone back? Is there any...
Great. There's a Professor Almeida who did the first English article on this. He showed grafting on his cases, and I didn't. I did one after a while. Here's my thinking.
Um, the area of the mucosa that covers this implant on the nasal side is pretty robust. It's pretty thick mucosa. It's not like a sinus membrane at all.
Right.
It's not mobile mucosa. In fact, the way I describe it in courses, if you pick your nose, you don't even get to the bony nose. You're in the soft tissue nose. You don't even get back there. So you're not in area of mobile mucosa. Nothing's hitting it. It's not being compressed. However, the idea was to graft that to cover the threads of the implant there, not necessarily for osseointegration, but to protect the nasal mucosa. Problem with that is this implant is not, this is my argument against it, by the way. The implant is not, that part of the implant is not in the narrowest part of the nose. The narrowest part of the nose, first of all, is in the soft tissue nose, not in the bony nose. And the narrowest part of the bony nose is on the medialmost aspect of the inferior turbinate, right? So, and we're lateral to the medialmost aspect of the inferior turbinate. So we're not in the narrowest part of the nose. So I don't see us narrowing airway space unless you graft. If you graft, you could potentially bulk that out too much and narrow the airway space. And then you are compressing that mucosa. Now, there's a new implant that I helped design that has a bald, non-threaded portion on the mid shaft of that implant so that you can, and it's timed such that the hex works, that the medial aspect underneath the mucosa there does not have threads. So it does away with that whole argument. And as far as grafting for increased stability, I'm getting typically 60 Newton centimeter torques on these. It's cortical bone, it's hard bone. That's generally what I'm looking at. So
I
I
see.
will graft.
I see.
Can you talk a little bit about your indications as far as, and maybe even mention too, like transsinus? I know we've gone through this on the podcast before, but when you're doing a transsinus, when you're doing a transnasal, how much crestal bone do you like to have?
Right.
How much apical bone do you like to have? When you're doing a transsinus, are you typically, lifting the membrane? Are you going through the membrane? What are your indications for doing both of those? I think that'd be really
great.
helpful.
You guys are great. These are great. So first of all, yeah, I do lift the membrane. It's not that big a deal. It's almost like an aside. Get a good round diamond burr and get through the bone and lift the membrane. Can you do it without it? Sure, but what can happen? I don't know. We saw a lot of sinusitis from the OG method of zygomas. So why not stay outside the sinus, just like we do with zygomas now? So as far as amount of bone, so the literature supports, and that's Ole Jensen wrote about it, like I said, and Malo also, that you need greater than 3 millimeters of subantral bone to not need to graft, to not need to do a sinus lift. So I use the same thing. I want more than 3 millimeters of subnasal bone as my crestal anchorage. The literature on the transsinus suggests that you need 2 millimeter thickness of lateral nasal wall. And generally, yeah, that's what you have. I just double it kind of empirically. I just said empirically, if we can do 2 millimeters of lateral nasal wall thickness for a transsinus implant, which goes through the lateral nasal wall more perpendicular, this is going more parallel along the lateral nasal wall. So I'm just going to say I can do double that easily. So I aim for 4 millimeters. I'll hit that inferior turbinate point and then enter at 4 millimeters superiorly for apical anchorage of at least 4 millimeters. So I got an 8 millimeter implant, essentially 4 millimeters at the apex and 4 millimeters at the crest, and I got good stability.
And in order to, because I want to make sure everyone's appreciating what you just said. So you're saying you're doing the transsinus and you're actually targeting the Z point itself for your apical anchorage. Is that what you're saying? Or
no. That's really hard to. That's hard to aim for that.
That's why I'm.
Anytime you go from the transsinus, you're going through the sinus. What bone are you going to hit? You're going to hit the lateral nasal wall.
Of course. Yeah.
I suppose you could, if you're that much of a sniper, expose the lateral nasal wall and triangulate. Yomi could do it.
Yeah, let's get Clark started on Yomi.
Yomi, good. But I don't. I just, that you have 2 millimeters of thickness. You already looked at your CT scans. You know what you have. and you're going, like I said, you're hitting that more perpendicular. You're not really tangentially hitting that lateral nasal wall. That's not really the apex. It's nice if you could hit it, but that's not part of that.
Yeah,
Okay.
I was going to ask your opinion on, a transsinus that goes up to the Z point there. I've always avoided that, for fear of it's much easier to hit the NLD from a posterior approach
Absolutely.
than it is directly visualizing that. So I wondered if you felt the same.
Absolutely. I think that the idea here is, especially if you've opened the sinus window, is to hit that curvature of the anterior wall of the sinus where it meets the lateral nasal wall. And
Yes.
you can almost see it if you need to. If it's really thin, you could actually watch it come through the facial aspect of that bone, the apex coming through if you need it.
Correct. I have another question for you. I've probably completed 20 transnasal implants, and maybe a touch more, but probably about 20. Do you, if I liked calling it, you call it crestal, or you could call it the coronal entrance point. So kind of walk me through. There's a little bit of a learning curve because you almost have to not over widen your osteotomy at the crestal aspect, but you need to have a little bit of degrees of freedom to really kind of get your pilot drill back there. So I wondered if you could just kind of walk through
Sure.
an initial prep.
Yeah, sure. So first of all, I generally will mark lateral incisor and junction of second premolar, first molar. I'll mark that on the alveolus. That's going to be my ideal positions for the 4 of an all-on-X, all-on-4 part of an all-on-X. So I'm going to keep that. I know that Vanderlyn talks about if you need, depending on the lateral wall thickness, he moves that laterally or medially, but I'm going to idealize that position, lateral incisor, let my access hole be in the cingulum of that lateral. It just, they all look alike that way. And I'm going to start my osteotomy with a Lance pilot drill, the Neodent 2 millimeter sharp pilot. The beauty of that burr is that it only cuts in the part of the tip that has sharp sides, flat sides. So
Right.
the long shaft doesn't cut. So you just get through. Again, you got to be palatal to the crest at this point. You get through into the nose. It almost doesn't matter where you end up in the nose. You just want to see it underneath the mucosa. And once you're up there, then you start directing laterally, visualizing that point that you're aiming for, aiming, coming in and out of that osteotomy, because it's the only part you can direct it or change the direction is down on the tip of that burr as you go in and out until you get right where you want. Now, the same thing goes for anteroposteriorly. Same thing. You're just using that 2 millimeter drill. Once you get to that, and you really have to direct the burr because it's going to want to skim along the medial aspect of the nose. Once you get into that point, again, you hit it. You can see where the lines are on that burr and just go another 4 millimeters for your apex. And then switch to what I use. I've used the Neodent Helix long burr until for a long time, until the Norris pterygoid kit came out. And the Norris pterygoid kit has an implant specific burr. And that one is a conical burr the whole way that cuts the whole way. Again, not just the tip. I'll use that. Once I use that pilot drill, I'll use that next drill as my final drill. And I'll go right again, watching it hit that apical target, that osteotomy that I made at the target spot, go in another 4 millimeters, and that's my osteotomy.
Okay,
So
that's
it's
to
a
say that
highly tapered
Yes,
drill.
right.
So
It's
that way you're able to, you have some freedom there on your
right.
coronal
The
or your
again,
crestal
I think
aspect.
I really formed that direction with that pilot drill first. the 2 millimeter, and then I go to it's a 2.3 to 3.2, I think is what it is.
Okay.
And then just follow it with that. But again, it's got to be under direct visualization.
Oh, totally.
I think that direct visualization thing is so key in not just this, zygos as well.
Yeah, I'm always interested with how lazy people can be. Every case, and I teach and encourage everybody, on even on your standard easy case, still lift the nasal mucosa.
Yeah.
I feel that I have so much more control of my case when I know exactly where all of my drill tips are.
I think that I'm going to use this as a kind of symbolically when I say that the thing that's important for an archer, for an arch surgeon, is to lose the loops. I mean, you could use the loops. Don't get me wrong. I don't use them, but lose the loops because you've got to see the whole picture.
Yeah.
And it's not just even seeing the whole arch. It's when you strip the nasal mucosa and you're seeing this just like your model. I mean, it looks exactly like that. You know what you're looking at. You just see so much more. So it's almost like symbolically losing the loops, seeing the whole picture. I think that's important.
Yeah, no.
So,
totally agree.
something I've struggled a little bit with intraoperatively, and I couldn't agree more about visualization, illumination. All of that is what really makes full arch doable and fun, frankly. But something I've struggled with is I routinely lift nasal mucosa to ensure engagement whenever I'm trying to do that with traditional on-4. But I've many times gone hunting to figure out, where's my Z point at. And I've tried to, kind of go up that lateral nasal wall and figure out where I'm at. And I have a harder time with it. Do you have any tips about how to expose that intraoperatively, identify that anatomy? Or there's some things to just kind of help us find our way through the dark there?
Yeah, I think so. I think that first of all, you should study your CAT scan first. You can almost measure where that is. Now, the tendency is not to go deep enough. And you don't need to go very deep. You don't want to go very deep because you don't want to encounter nasolacrimal duct. You want to be anterior to that no matter what. But as you start to strip, I'm also, by the way, when you strip, I tend to want to strip widely and then go deep as I'm wide. So in other words, I don't want to tunnel. So I'm going to strip the nasal crest of the maxilla straight along the floor, up the side of the nose, as high as I feel like I need to go, and then go a little deeper each time. So I have the floor of the nose exposed, and then as I come up the side, I can go a little bit deeper, and my periosteal is going to stop, or in my case, I use a nasal freer. My freer is going to stop when I get to that widening at that turbinate. So the anterior-most point. If you're too far anterior, you didn't hit the turbinate yet, you're going to go as high as you want because there's nothing to stop you superficially or not deep in the nose. Go a little deeper, you'll get to that widening.
I see. Okay.
I've also kind of found that it's if you find your infraorbital framing, it's typically right about that same line. Would you agree?
Yeah, it is, but that's a variable point to me. So the other thing, by the way, is Cesar Guerrero, by the way, has an atlas from years ago, and he did a series on infraorbital using the zygoma implant with infraorbital rim anchorage. Not something that I would do, but the idea is that you can go higher along that lateral nasal wall and still avoid the nasolacrimal duct to get to that point. You can go higher if you need to, if that's where the thickness is. In fact, I was at a live surgery course in Brazil, and I was tasked to do a revision on a patient that came back with failures, and there really was no way to get anchorage at the typical transnasal point, and I just had to go up to as close as I could to the infraorbital rim to get anchorage. So there's nothing there to stop me as long as you see it on the scan ahead of time what you're avoiding. But yeah, generally that's at the level of the inferior turbinate is parallel with that.
Also in that book you referenced, there's zygoma implants in the mandible.
Yes. Yeah.
Oh boy.
That's counting on apical anchorage, isn't it?
Yeah, no kidding. So I fortunately had a skull on hand just to kind of be steady. I don't know if I can get the camera to focus on it,
There
but
it goes.
I did look because I what you just said was very interesting, Clark. You said the infraorbital being right at the same level as that turbinate, and at least in this model, that's
I would,
fairly accurate.
I mean, I think it'd be in the
I already
neighborhood.
got one too.
It's a reference
one
point,
too.
right? It's
Yeah.
something just to kind of give us a little bit of geolocation. Oh, Dave is getting his skull as
I'm
well.
sure David
And I
has a
did
real
notice
one.
Oh,
Yeah.
look at this.
You got the T1000.
And he really has it too.
Oh, that's fantastic. But I also, I mean, just looking at this, I mean, it all comes back to just knowing your anatomy. I can tell too is, a lot of times when I've been looking for this, I'm not going posterior enough.
Right.
It all
Right.
feels really smooth, and I'm like, oh,
And-
I guess anatomy's not there, but it's
That's
back
it.
there.
But look at it. If you look at it on axial slices, you can see just how far back you
Yeah.
really have to go to even involve the nasolacrimal duct. So when Simmons
Okay.
said that the average of the anterior part of the inferior turbinate to the nasolacrimal duct on average is 15 millimeters, you got some leeway. Now,
Yeah.
not every patient, no patient is average. All of our kids are above average, but in this case, you should look ahead of time and you'll know where it is. But it's deeper. It is deeper.
I see.
Can you talk about some of the complications around your transnasal and like what you've seen, what you've had to fix, and maybe just some like key points of absolute no-goes? And I know you just talked about how the class 1 is
Yeah.
typically one that you shouldn't do, but for as we're seeing more and more people venture into remote anchorage, and maybe people that shouldn't be venturing into remote anchorage, I'm sure you're seeing more and more things that are big no-nos that I would love to go over.
Well, I'll say I really think I only had one transnasal implant that failed. And it turns out it was a patient that I couldn't get anything to stick on. I finally ended up with a quad that so far so good is working. But it was like sometimes it really is the patient. You throw the same thing at everybody, and usually it sticks, right?
Yeah.
So I mean, it was a smoker. I'm not blaming that. It's just nothing seemed to stick on this guy. As far as complications, I have not seen any epiphora. I've not seen any damage to nasolacrimal duct. Nor have I had to treat that, but I know that that's out there. Certainly from trauma it exists, but as far as transnasal implants, it's failures. I've not seen. I have seen tears in nasal mucosa, dehiscence that I was able to treat with local flaps, and not GBR, but just membranes, and that worked out fine. It really, you can hug, as long as you stick with the principles. It's like everything else in life. If you stick with the principles, you hug the lateral nasal wall so that you're not far off of that. You're not expanding against the nasal mucosa, and your anterior to nasolacrimal duct. This is an implant. I mean, this is a good solid implant, and use the right implant, by the way. It's important to use the right implant. So the aggressively threaded implants are not made for this. They're just not good. The bone is extremely cortical bone. It'll crack. You'll crack the maxilla. You'll be sorry you did it. So there are implants out there. There's just from a company standpoint. Neodent Helix Long was the gold standard. Norris now has one that's specific for this. I think that as long as you have a finely threaded implant with a narrow apex, you're good.